Good afternoon. My name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for the MAVEN Project. Thank you all for joining us today, and our friends at Puyallup Tribal Health Authority in Tacoma, Washington, for requesting today's session, Common Lumps and Bumps with Dr. Howard Pride. Dr. Pride is a board-certified dermatologist who has been practicing pediatric dermatology since the early 90s at Geisinger in Pennsylvania, where he served as chairman of the dermatology department for 6 years. And now he's working for the Carillon Clinic in Virginia. He is the co-author of a textbook of pediatric dermatology and has published numerous peer-reviewed articles and book chapters. In addition, Dr. Pride has been the director of Camp Discovery in Pennsylvania, formerly known as Camp Horizon, a camp for children with chronic skin diseases, since its inception in 1995, and has been the chairman for the American Academy of Dermatology's Camp Discovery. He has received presidential citations and the AAD's Golden Triangle Award for his work with CAMP, and was also past president of the Society for Pediatric Dermatology. Dr. Pride, welcome, and we're so pleased to have you here today.
Thanks, Jill. And thanks for the invitation to speak with you. Just to kind of get the housekeeping out of the way, I have no disclosures and no conflicts of interest to talk about. So the topic that was requested was lumps and bumps in children. My practice is pediatric dermatology, but I will say for those of you whose practices overlap the adult and pediatric world, most of the things that we're talking about are seen in adults as well. So I think they'll have some clinical relevance regardless of the age of the patients that you tend to see. And it really is going to be kind of a smorgasbord. It's not something that really follows a theme in terms of pathogenesis and that sort of thing. So we'll be jumping all over from topic to topic, with the common theme being that these are things that are lesions that I see in children. The challenge for me is to come up with things that are clinically relevant. And I think even though these are things that aren't coming in every single day, they are things that will appear in your practice, but not to pick things that are just so banal as warts and pimples and mollusca warts and that sort of thing. So hopefully you'll find this interesting and novel, but not so obtuse that you feel like it's not clinically relevant to you. So let's get started. Each of the topics will start with kind of like what the chief complaint might be. So this is a lot of the times what's on my schedule is this is ringworm that nothing seems to be working on. So good example here, it's perfectly circular. And for all the world does look like ringworm. I don't think I've ever seen anybody with this entity that either the doctor treating them wasn't treating them as tinea or the parents weren't treating them as tinea, and it just doesn't respond. And different patients, but you'll see a pretty common theme here in terms of the classic location and classic morphology. What might strike you as you're looking at the picture here is, unlike ringworm, unlike tinea, there really is no scale to this. And it's hard to picture photographically, but if you ran your hand over the top of that, I think in your mind's eye, you can imagine that there's a little bit of induration to it, a little bit of substance to it, a little bit of a rolled border. So perhaps many of you, recognize this as granuloma annulare. Again, this is not something that's rolling into my clinic every single day, but it's very, very common. So if you haven't seen it, I would bet that it has seen you. And I'm showing you the classic location here, but the side of the ankle, back of the hands are other areas that you might see this. So other examples here, sometimes hard to photograph, but again, if you run your hand over the top of this, you get the sense of kind of a deep induration. And again, a very striking absence of scale, which would be very unusual for tinea. Another example here. And you get the sense that a lot of these are starting to look pretty much alike. So as a kind of a general rule, if you've got annular erythema, but without scale in the classic locations, dorsal foot, which was virtually all the pictures that I showed you, ankle, or dorsal hand is fairly common as well. There's an entity called deep granuloma annulare, which is a little bit more subtle, I think, to put together, which is usually on the shin. But the more superficial annular, more visible granuloma annulare, back of the hands, ankle, and instep of the foot. So if you're persevering on tinea and things aren't getting better and it's in one of those locations, the light bulb should go on, probably granuloma annulare. And here a good example on the ankle, again on the ankles. All different examples, but I think you get the picture of an annular erythema without scale. And a little less annular here. So there are times that the diagnosis is not as perfectly obvious when it's perfectly annular. Back of the hands, this obviously on an adult, not usually that obvious, but it makes a great photograph. And it can be in non-classic areas. It can be truncal. And in our adult population, a little bit more likely to be disseminated all over the body. Here at the bottom of the foot. Again, this is a little bit more subtle and would be a little bit harder to pick up clinically. And, even on the penis, so, I don't think there's any place neck downward that I haven't seen granuloma annulare, but those classic areas should really jump out at you. So classic locations, again, back of the hands, instep of the feet, ankles, and sometimes elbows and knees as well. And again, the real lesson that I want to hammer in on this, if you're persevering that this looks like ringworm, looks like tinea, and it just isn't responding to treatment, and you feel it, and it's got that induration, it has no scale, the light bulb should go off that you're dealing with granuloma annulare. And again, it's got a deeper feel to it, an infiltrative feel, particularly at the borders. Um, Now, it doesn't have to be treated. It's self-limited, even though it's very long-lasting. So people might have granuloma annulare for a year or two or even longer. It's not usually terribly symptomatic. So some people are bothered by the way it looks, or there might be some slight itch to it. But given that the treatment that really seems to work the best is intralesional steroids, not every child that I'm seeing with granuloma annulare really is too excited about taking me up on that offer to poke a needle into it. That's what really works the best. Our super potent topical steroid used, topically can be a little bit effective, but if you were to see a biopsy of granuloma annulare, all the inflammation is down deep in the skin, and topicals just don't really get there very well. So some people really are dying to have it treated, but not dying to have a needle poked into it. A super potent topical steroid, clobetasol, betamethasone dipropionate, something along those lines, might be a little bit effective. And again, chronic, many months at least, sometimes a few years, but generally in most people self-limiting, even if you don't do anything. So with many of the young children that I see, they're more than happy to just leave well enough alone and move on. So lesion at the lateral eyebrow. I can almost bet what this is just by the chief complaint alone. So this might be the young child here. Not really much in the way of surface color change. Many times they're right from birth, but not always. Sometimes these seem to come on after birth. And you palpate that, and it's got kind of a rubbery, firm, but not rock hard feel to it. Again, lateral eyebrow. You see left lateral eyebrow there. They're all starting to look the same here. Again, left lateral eyebrow, just above the rim of the orbit. And again, all different patients, but very, very similar presentation. So when I see this, I'm either thinking a deep hemangioma, but that is a little bit more dynamic than this. This once it appears, it's pretty well set, whereas a hemangioma goes through a growing phase and a shrinking phase. These are not terribly dynamic. The other thing is going to be a dermoid cyst. So really common classic location of a dermoid. Very harmless. So they're not things that necessarily need to be imaged or biopsied. And I think it's up to every parent to kind of make a decision whether they want to have it excised or just leave well enough alone. So again, classic location here. Now, this is different. This is a dermoid cyst, but we're getting into a whole different conversation with this. This is midline on the glabella. And these are a little bit more intriguing and thought-provoking because anything midline glabella has the possibility of having some extension centrally, whether dermoid or encephalocele or meningocele or nasal glioma. So these, where the lateral eyebrow ones, pretty much at any time that a parent wants, I'll send a plastic surgery or general pediatric surgery to have excised. These need some imaging before anybody pokes into them. So this would be something that would send for MRI or CAT scan beforehand. So central glabella is entirely different in terms of the urgency of workup compared to the lateral eyebrow, which is far and away the more common location, which is something that can just be excised without doing any imaging. So again, here, beware the differential diagnosis in this setting, nasal glioma, meningocele, encephalocele. So you can get yourself into a ton of trouble putting a punch biopsy or trying to drain or something like that. Imaging is definitely required, but that's a whole different area than the dermoid cysts. So they're congenital. They're there at birth, but they might not get noticed until several months of life. So the parents might not say that they noticed it right at birth. Um, and they're firm, but they're rubbery and movable. They're not the palpation that you get with something that sends a chill down your spine, rock hard and fixed to the underlying tissue. They've got a much more benign feel to them, but still fairly firm. And again, the lateral eyebrow, the absolute classic location for this. And again, parents might opt to leave it alone, which I think is absolutely fine. And some parents might say this is unacceptable. The child is not going to want to have a lump on their eyebrow when they head to kindergarten, and getting it off is absolutely acceptable as well. So that's an individual family decision from there. All right, my child has a rock in their skin. This is along similar lines to what we just talked about, but a different form of cyst. This one you feel, and it's not smooth and circular. It's much more multilobulated, firm, and really rock hard feeling, but not fixed to the underlying tissue, not that same feel of a malignancy that really scares you. And a lot of times with a little bit of a bluish discoloration over the top. So blue, rock hard, and classically on the face, you pretty well got your diagnosis, just from that. And here, because these will tend to be calcified, um, they'll have a chalky appearance at some point. So this one, you can actually see the calcium within it. So this is a type of cyst called a pilomatricoma. And again, this might be something that you're thinking, boy, I've never seen this, but I would be more than willing to bet that it has seen you. These are not that uncommon. So again, classically on the face, very hard, but not fixed and multilobulated. Couple of diagnostic signs that might be helpful with this. So there's what's called the tent sign. And you can kind of see that with this cyst, that there's like two posts sticking up there, like a tent. The other is what's sometimes called the seesaw sign or the teeter-totter sign. So this is when you palpate on one end, one of those little spikes that's coming up, the other end pops up. You push down, other end pops up. You push that end, the other end pops up, just like a seesaw going back and forth. Those can be really helpful diagnostic signs with a pilomatricoma, but I will tell you, it's not absolutely present in every single last one. So they're fairly slow growing, very irregular, and very mobile. So again, even though they're very, very hard, they're not fixed to the underlying tissue the way a very significant malignant tumor would be. And very frequently, they have a blue overlying hue, and usually on the face, for whatever reason, there's a marked female predominance. And I have seen some of these shrink or seemingly disappear. My guess is microscopically, there's still a piece of it there. But if you can't see it and you can't feel it, that's pretty much the same as going away. But many parents do opt to have these surgically removed, and they come out really nicely. So, like the dermoid cyst, a parent that wants it removed, fine, we send them to plastic surgery and get them off. A parent that says, okay, if they're not a big deal, leave alone, that's absolutely fine as well. So, scalp birthmark. Now, I don't know what this is absolutely positively, but I've got a pretty good idea of where this is going when that's the chief complaint when the parents come in with the scalp birthmark. So this is one example here. Weird, kind of orangish, sometimes bright yellow hue to it, kind of lancet shaped, but usually at least oval in shape, and kind of lobulated and even a little greasy, particularly in newborns with this entity. Another example here, a little bit older child, so it's a little bit flatter and not quite so multilobulated and greasy looking. Another example here, a little bit harder to see the color. Another example here, but you kind of get a feel, I think, for the, orange yellow kind of mix of colors with this. Another example here. Usually minimal or no hair growth through it. So hopefully you recognize that yellowish color as being sort of the color of sebaceous hyperplasia, sebaceous glands. So this is a nevus sebaceous, a nevoid birthmark of sebaceous tissue. So if you biopsied that or removed it and got pathology, it would just be chock full of these sebaceous glands, normal sebaceous glands collected in an abnormal fashion. And they're not always on the scalp. I mean, when they're on the face, they can be a little bit more subtle. Um, and as they make a transition from scalp skin to more regular cutaneous skin, they have more the look of an epidermal nevus, a little bit more warty as opposed to a nevus sebaceous. We're going to talk a little bit about why a nevus sebaceous will transition into an epidermal nevus as it comes off of the scalp and onto the body. There actually is a genetic explanation for the similarities there. And here on the eyelid, same kind of yellowish multilobulated look to it. And rarely, but sometimes, these will grow little goonies off of them, and we'll talk about some of the bizarre names that these have. So we call them tumors, but they really behave in a very unaggressive, benign fashion. But while some parents might be on the fence as to whether they're going to get them removed or not get them removed, once a goonie starts growing out of it, that's usually a deal breaker for most parents, and it's time to get rid of it from there. So a nevus sebaceous represents a postzygotic mutation. We're going to talk a little bit more about what that means in a little bit. And the genetic abnormality actually was recently discovered. So we actually know what genetic abnormality occurs in a postzygotic fashion. And they're virtually always on the scalp, less commonly on the face. And that yellowish kind of pebbly color is really characteristic and sometimes kind of greasy depending on where they are in the stage of a child's development. And almost always with no hair, or at least little hair. They're because they're on the scalp, they come off easier when they're removed as infants, because an infant's scalp has a lot more laxity to it. So if there's a parent that knows this is coming off, generally getting it done as early as is safe for general anesthesia is the best thing. Now, not everybody wants them off. So a parent might say, this is their scalp. They're the one that's got to go through the procedure. Let them make a decision when they're older. I think that's reasonable. But if a parent knows it's coming off, the better it comes out, the sooner it comes off, the better it will come out. So I will encourage parents about 1 year of age to get them off if they're pretty sure that this is a cosmetically unacceptable lesion, and they want to get it off early. That makes the surgeon's job a lot easier, and probably the end scar is a lot better. And again, as we discussed, there is this possibility, and the percentages vary. I think 5 to 15% is probably a pretty good number. It's high, if anything, degeneration into these benign tumors. And trichoblastoma, which had been mistaken as basal cell carcinomas, is one of the more common, and syringocystadenoma papilliferum. If you're looking for a tongue twister to say 5 times fast, that would be a good example. Are examples of things that will grow out of these. Now, another birthmark on the scalp, but fixed and not yellowish or lobulated or greasy like a nevus sebaceous, is shown here. So this is part of the differential of a scalp birthmark, is aplasia cutis congenita, an area that didn't form normally developmentally. So this is the typical one that's very scar-like. This one membranous, so hasn't quite totally healed over yet. And while they're usually nice distinct circles, they can be much more spiculated, as is shown in this picture. So nevus sebaceous differential diagnosis is aplasia cutis congenita. And frequently, these will be seen with these little hair collar signs. Hair collar sign has some significance in that it's one of several cutaneous findings for dysraphism, or connection to the central nervous system. So that's something that we take seriously. Now, just having aplasia cutis congenita and a hair collar sign probably is not in and of itself enough. But you get something like this, where you've got a growth and a vascular stain, or like this, you've got this little area of that's not growing hair, purplish color, the hair collar sign, and you can see a subtle vascular stain. You start mounting up these physical exam findings. This is definitely something that needs some imaging. So I'm getting off a little bit on a tangent from the differential diagnosis of a scalp birthmark, which usually is going to be nevus sebaceous. Again, they're harmless, but if they're going to be removed, you are doing the surgeon a favor by removing them as soon as general anesthesia is reasonable to do safely. Now, probably the other thing that I see a ton of on the scalp, not necessarily as birthmarks, are weird moles. There's something about the scalp that develops the most unusual looking moles. So the nickname we tend to give these are eclipse moles because they look like a lunar eclipse where the moon comes in front of the sun and then you get this corona around it. I would bet a week does not go by where I don't see one or two of these in clinic. So they're very, very eye-catching. So whether you're an astronomer and inclined to call it an eclipse nevus, or you're a Homer Simpson fan and call it a donut nevus, you kind of get the idea. Light center with a darker corona, or it can be the opposite. Um, so it's important to know because these are extremely eye-catching, but really of no clinical significance at all. And you're generally seeing these on young children where the incidence of melanoma or bad moles is just excruciatingly low. Pre-pubertal children, the incidence of melanoma is about 1 in a million. Early puberty, middle school age, maybe 1 in a quarter million. So just at baseline incidence, melanoma is not going to be real high on your differential diagnosis list. But I get a ton of consults for these so that I know they must be concerning to parents and referring doctors. So if you keep the sort of the image of a lunar or solar eclipse in mind, you won't be stunned by these. One thing to keep in mind is that there are certain histologic special sites on the body, the scalp, the armpit, the groin, so that when benign lesions are removed from these areas, they tend to show atypia. So I've had a few children that I sort of get as the end referral that had the odd scalp mole removed, and then it's read as atypical. So they get a re-excision to get a wider margin around it. So the poor child has had 2 procedures and a big scar, really for something that would have been just best left alone. So again, other examples here. My collection of clinical images is just chock full of these. They're just amazingly, amazingly common. So if you see that on the scalp, and frankly, in a child on any other area of the body, you can ignore it. It absolutely is going to be okay. So let's get back a little bit to the nevus sebaceous thing. And we talked about it being a genetic mosaic or post-zygotic mutation. What is a mosaic? Well, in a literal sense, the mosaics are these really elaborate artistic creations made out of tiny, tiny little stones or tiles with these beautiful like swirls. And you think, boy, there's nothing that occurs on the body that looks like that. Well, yeah, there are, and this is part of my world of seeing kind of weird birthmarks. But anything that is a post-zygotic mutation, in other words, a mutation that occurs after many, many divisions of the cell, will give these kind of wonderful artistic looking shapes of swirls on the body and kind of V's and swirls on the back and linear stripes on the arms. So what is a genetic mosaic? And the reason I bring this up is that many, many of the lumps and bumps that I see in children, their origin is in that of genetic mosaicism. So this is just a cartoon that I've made to kind of illustrate this. So you've got a happy little postcoital kind of like fertilized egg in the middle there, and it goes through a number of divisions. And the sweet spot for actually getting a clinical genetic mosaic is usually in the mid-teens. So in the mid-teens of gestation, where the child is just this tiny little ball inside of its mom, a lightning bolt occurs. There's some genetic mutation in one cell. So the whole organism otherwise is forming normally, and then one cell mutates. And each daughter of that cell carries that mutation and then becomes the birthmark, where the rest of the body develops normally. Now, the teens are kind of the sweet spot with this. If the genetic abnormality occurs much earlier than that, it's probably not compatible with life with most genetic abnormalities. And if it occurs much later than that, it's so insignificant that you don't really even see it on the skin. And if it's of ectodermal derivation, then it follows these wonderful, artistic, beautiful lines where we see the birthmarks following these very characteristic patterns that are called Blaschko's lines. But depending on whether ectodermal, mesodermal, endodermal, the patterns can be a little bit different. So there are other patterns that represent genetic mosaicism, with the genetics of it being the same concept of one cell mutating many, many divisions into the forming organism, and then the daughters of that mutation forming the birthmark. I think it's really, really fascinating to understand and then to actually see it clinically. So this is an epidermal nevus, kind of a warty looking growth, and a lot of times mistaken for a wart, but in a perfect straight line. So this would be on an extremity where it's on a straight line like this. So epidermal nevus. Now you look at the blow up of the picture on the right. For those of you that take care of adults, it looks a lot like a seborrheic keratosis. That's a seborrheic keratosis on adult, an old age spot, if you will. Um, so, this is something that anybody that sees adults or does skin cancer checks or that sort of thing, you see these all the time. There's hardly anybody, I don't know, 65, 70 years old or older that doesn't have these. So they look very, very similar. And the significance of that will come to the fore here pretty soon. So a little bit bigger. Now, why is one bigger and why is one smaller? Well, it probably depends on when the genetic abnormality occurs in gestation. So the earlier it is, the bigger it is, and the more it affects, more surface area it affects, and the later it occurs, the more small it will be. And a little bit different genetic abnormality here, but a different form of epidermal nevus with epidermolytic ichthyosis associated with it. So, these are relatively common and absolutely harmless as can be, but a lot of kids don't like them very much. And if they're in a highly visible location, a lot of them are looking for some treatment. So generally, it's best to wait until early grade school because, even though the seed has been planted before the child was ever born, they do lengthen up until usually about kindergarten, first grade or so. And then the skill with this is to take off just enough down into the dermis to prevent it from coming back, but not leave a horrendous scar. Because if it's done very superficially, invariably they come back. And if it's done too deeply or too destructively, then you leave a scar that's worse than the lesion. So these are tough in terms of hitting it exactly right on the nose. And other destructive modalities like cautery or cryotherapy can be done. Now, the genetics of what gene is mutated in these is a relatively recent discovery over the last 10 years or so. And with an epidermal nevus in particular, it's actually several different genes. Um, but interesting to note that fibroblastic growth factor receptor 3 is actually the same gene that's mutated that leads to the formation of a seborrheic keratosis. Well, no wonder that they look so much alike, as well as PIK3CA, also seen in some seborrheic keratoses. But a really interesting thing is that the HRAS and KRAS mutation that we talked about with the nevus sebaceous also is in some epidermal nevi. And a really fascinating observation is looking at a nevus sebaceous that starts at the scalp, stretches down the neck, and goes onto the chest, one that's fairly large. In the scalp, it's got all the morphology of a nevus sebaceous. On the face, it's in a transition. It sort of looks like a epidermal nevus and a nevus sebaceous. Then around the neck and the upper chest, it has the look of an epidermal nevus. So it's not just the genetic abnormality; it's the geography of where it is on the body that gives its phenotype. Really, really fascinating. Um, my old high school physics professor used to say, if that doesn't turn you on, you ain't got switches. To me, this is really, I think, very fascinating and really interesting to see clinically on the skin. All right. I wouldn't say this is one of the more common things that I see, but I think it's a really good thing for you to know about. So the chief complaint is it's a congenital nevus because it's got hair and looks like a congenital nevus, but there's no pigment in it, which is kind of an oxymoronic thought when you think about it, that you have a congenital nevus, but it doesn't have any pigment. So these are hard to photograph, but you see, we're looking at the hip in this child, and there's this weird kind of tuft of hair and a little bit of hyperpigmentation, and hard to appreciate in the photograph, but a little bit of kind of chicken skin, goose flesh kind of texture to it. Another example here. These are really hard to capture photographically. Another example on the thigh here. So you see the where we're looking, you can just barely see the diaper on the upper left hand. So we're looking at anterior thigh. But same thing, kind of this tuft of hair like you sort of expect to see with a congenital melanocytic nevus, but no pigment, which seems kind of strange. I mean, how can you have a nevus without brown pigment in it? So this is actually what's called a congenital smooth muscle hamartoma. So this likewise is a postzygotic mutation that forms, in this case, smooth muscle. Smooth muscle is what attaches to our hair follicles. So when you're watching a scary movie or you're outside and it's real cold and your hair stands on end, that's from contraction of smooth muscle. So this is an abnormal collection of smooth muscle. Now, unlike epidermal nevus and nevus sebaceous, the genetics of this are not known. So we don't know exactly what gene mutates to cause this. But you look at the difference between this and a congenital nevus, and I've tried to take pictures clinically of kind of the same geography. So a congenital smooth muscle hamartoma is very, very light, almost flesh colored, where a congenital nevus is going to be dark, dark brown, even black. A lot of follicular prominence or goose flesh sort of texture that's not seen in a congenital nevus. There's what's called a pseudo-Derrier sign. Now, a real Derrier sign we have yet to talk about, but we're coming up on that shortly. But what that means is you stroke the skin and you elicit contraction of the smooth muscle, and the smooth muscle contracts and the hair stands on end, and you get kind of like an accentuation of the goose flesh. And, if it comes to that, a biopsy would tell you the difference. This is not something I would necessarily feel compelled to biopsy, but if the diagnosis is confusing, that brings some closure to parents. But these are as harmless as can be. So it's not something that we would necessarily do something about. As the child matures and gets older, if the dark hair is the thing that's bothering them, then laser hair removal could be considered. But it's totally impractical to think about surgically removing something like this. So we just leave them alone, reassure parents that they're absolutely okay, and move on. Now, you might be thinking that this looks a little bit like something that you've seen before. Older guy on the chest or on the scapula, like this, weird tuft of hair, but again, not much pigmentation under it, or at least light brown pigmentation, not like a congenital nevus, or another one here on the thigh of an older child. So this is what we would refer to as a classic Becker nevus. Typically, adolescent or just barely pre-adolescent, almost always boy, classically scapular and chest, though they're histologically pretty much the same as a congenital smooth muscle hamartoma. So these probably represent postzygotic mutations as well, representing mosaicism, just like we've been kind of talking about. So there's a line of thought that they're actually the same thing, just appearing in a different age group and a different setting. So different examples of Becker nevus there. Brown spots that hive. So this looks like a little guy that's maybe speckled with some small moles or that sort of thing. But the parent will say that areas of friction, like in the pant line or the diaper line, that these tend to kind of get hive-like, and then they'll settle down and go back to their brown spot. Another example here. Now, I've elicited this one. So brown spots that almost look like moles. But if you give a good rubbing to one, like I've done here for the photograph, it'll hive up in the matter of 2 or 3 minutes, and then slowly but surely settle back down to its brown state. Other examples here. So it's kind of cruel to do to the poor child just to make your diagnosis or to get a good photograph, but it's at least less invasive than doing a biopsy. So you get the picture here. All of these are fairly similar. So this is a true Derriere sign of a mastocytoma. Mastocytoma, an abnormal collection of normal mast cells. So now we all know what mast cells are. We're painfully aware of mast cells. We have a lobster or a dose of penicillin or something like that and break out in hives. That's release of histamine and serotonin and prostaglandin from mast cells. So this is an abnormal collection of mast cells, either in a single lesion or frequently somebody who's just peppered with them, what's called urticaria pigmentosa. Other example here. So this is not one that has any hives, but you could see where somebody might mistake these as multiple moles. And so you can go from the gamut of somebody who's got one solitary mastocytoma to somebody that's peppered with maybe 50 or 60 of them, again, what we call urticaria pigmentosa, or to someone like this, which fortunately is really, really, really uncommon, what's called diffuse cutaneous mastocytosis. It's like their whole body is one big mastocytoma. And that's a disaster. So I'm not going to talk about that much, but just to alert you to that as an entity. So again, other examples of urticaria pigmentosa are multiple mastocytomas, many of them here. Many of them here as well. So you kind of get the picture. And again, if you want to make the diagnosis, you just take your finger and give it a good rubbing for about 10 seconds or so, wait about a minute, and you'll get this urticarial flare and underlying edema. Not much need for treatment. In fact, most of these we don't treat at all because children do get better. Ice, topical corticosteroids, antihistamines, oral cromolyn, all are minimally effective. In terms of knowing what happens with them, this is a study from, oh boy, 7, 8 years or so ago now, out of University of Wisconsin that followed a large population of these. And I'm not going to go into this in great depth because there are other things that I want to get to. But the main thing that I wanted to highlight is there were no cases of anaphylaxis among these children. In particular, they had many of them that were stung by bees and went through general anesthesia without any anaphylactic reaction. So the old adage of having all of these children get a really costly uh, EpiPen um, probably is not necessary. And I've stopped prescribing that for children with urticaria pigmentosa. All right, we're getting towards the end here. That's the weirdest shade of yellow I have ever seen in my life. So here's a lesion that came up on this child. And that is almost an unearthly mustard-like yellow color. So when I see that, I've got the diagnosis already. And hopefully after you've seen pictures of this, if you see it in the future, you'll make no mistake as to what this is. Um, Early on, though, they're a little bit more reddish. So until they develop that color, it can be a little bit more challenging. But this is a juvenile xanthogranuloma. Again, not walking into the clinic every single day, but common enough where this will be something in your primary care clinic at some point or another. Absolutely guarantee. This is a form of non-Langerhans cell histiocytosis. They're usually firm, roundish, oval nodule papules, and initially reddish brown, but then they evolve into this really strange neon yellow color, and there's just nothing like it. Um, Sometimes systemic association, particularly eye involvement, but very, very, very rare. And I think we're coming to the conclusion now that we don't need to go on a witch hunt with these. They're not always a single lesion. So something like this is a little bit more challenging, although the color would lead you in that direction. And making the diagnosis usually just by clinical appearance. Biopsy will give you the diagnosis, but it's really not necessary to biopsy these. And in terms of extracutaneous involvement, they can involve the eye. There's a line of thought that when we see these on the skin, we should be sending them to the eye doctors. But this is a study that I think settled this fairly well. And I'm not going to go into it in great depth, aside from just give you the bottom line is that there were some children in the study, a very small fraction, in this case, 5/2949, 2,000, well, close to 3,000 patients. But each one of the ones that had eye involvement had findings in the eye well before they ever presented to a dermatologist or the primary care doctor with it. So the thought that you're going to have one, two, three, four, or whatever JXGs, and then that there'll be something found kind of subtly in the eyes is not really founded. So we don't really need to direct all of these to the eye doctors, and they really don't need treatment. They do tend to run their own course. Usually, early grade school, they just disappear. Differential diagnosis, Spitz-Nevis, which is a whole 1 hour talk in and of itself. So I'm not going to get into that too much. And mastocytoma, we've already talked about. Kind of a variant. Benign cephalic histiocytosis is another non-X, non-Langerhans cell histiocytosis. Even though these have a brown color, they actually are juvenile xanthogranulomas with a little bit different look to them. So benign cephalic histiocytosis, it's been discovered over the past many years, are just juvenile xanthogranulomas, perfectly harmless. Um, my baby has bumpy feet. I suspect this is way more common than I actually get these patients referred to me. But you see at the heel of both of these feet, there's just this very subtle bumpiness to it. And you press on it and it's soft, like subcutaneous fat, buttons in really easily. Again, here, not terribly easy to photograph. Another one towards the heel here. So these are something that's called benign anteromedial plantar nodules. Um, because they're so harmless, I suspect they're way, way, way more common than making it into the clinic to see me. And they have the feel of fat, and that's actually what they are. So there's some thought that they're either hamartomatous, sort of abnormal or fat in an abnormal location, but I think more likely is they're herniations of the underlying fat through kind of a weak dermis, similar to a name you might have heard of, a pisogenic papules, little bumps that come up from the side of the heel in adults that are kind of herniating through the subcutaneous tissue. Um, harmless as can be, don't require any treatment, and you just reassure parents and move on. And then lastly, as we're talking about baby lesions, these kind of calcified, rock hard areas on the heel, um, kind of a chalky material coming out of them. So these are calcified cutaneous nodules, a fairly common area to see milia. In fact, there probably are little epidermoid cyst milia that then become calcified. And virtually always they're at some high-risk infant, ill infant that's had multiple heel sticks. So the heel sticks for, say, somebody that's had prolonged hyperbilirubinemia and had bilirubins checked as an infant, these multiple pricks on the heel will tend to lead to these. They're harmless enough. You can take a 15 scalpel blade and just kind of pare them down and get the calcium out. But just leaving them alone, eventually the body will exude the calcium and they'll disappear. But getting the story is really helpful that they had multiple heel sticks and the light bulb will go on and you figure it out. Um, this thing just will not stop bleeding. Little red bleb. Looks like a hemangioma, but then a child way too old to be a hemangioma. This right around the orbital rim is a really common location for these. Very friable. They bleed with almost no trauma at all. And when they bleed and bleed and bleed, almost to a point where parents will have to scoop the child up and go to the emergency room to get them taken care of. So these are pyogenic granulomas. I think you probably recognize these. So diagnosing not usually the problem. It's what are you going to do about it? So this is kind of tongue in cheek. Whoever's lowest on the totem pole, just hold pressure on this for about an hour until the bleeding stops. Um, that's obviously not a very good option. There really is very little spontaneous resolution with these, so just letting them go is not a great option. So they need some definitive treatment, and just infusing them with a little bit of lidocaine and taking a blade and doing a little bit of a scoop to the base, maybe curetting the base, and it's done. So, a problem that's been causing a parent like days of agony and trips in the emergency room, you really can solve in about 30 seconds. The key to this is just having a great nurse in your clinic to hold the child. The procedure itself couldn't be easier. If you're comfortable with doing shaves, this is just another shave. So I will tell my nurse, you are 99% of this procedure, and I'm just 1%. So holding the child is really, really, really important. But in fact, it's really not that big of a deal of a procedure. And you might put a pressure bandage on it. You might put a square of gel foam. Uh, if there's bleeding, a little electrocautery or silver nitrate can help with that. I've not had good luck with lasers. You'll see that in the literature. To me, it just doesn't work, and it seems destined to be somebody that's going to come back later on. There's been some success with timolol. You might have heard using timolol as a beta blocker that we'll use on hemangiomas that don't necessarily need systemic therapy with propranolol. So timolol we'll use on a hemangioma, but they might work on a pyogenic granuloma. So if I've got one very, very close to the eyelid margin on a child that's too young to hold still for an excision that close to the eye, timolol might be something that I would give a try to. All right, that that is it. So I think we've got a little bit of time before you guys have to head out to answer some questions.
Great. Dr. Pride, thank you so much for such an interesting talk today. We really appreciate that. So I wanted to invite anyone who may have any questions for Dr. Pride about any of the conditions that he reviewed today, or if you have questions about other types of conditions that you see frequently or infrequently in clinic, and any tips for management of those. You can feel free to, I think it's a small enough group that you could write it in the chat if you have any questions, or you can put it in the Q&A icon on our Zoom toolbar. Or if you prefer to raise your hand, I can try to unmute you. So I'll just give you guys a few seconds, give you some time if you can think of anything. And just while we are waiting to see if anyone has any questions, Dr. Pride, I'll actually have you stop sharing your screen. And I just wanted to remind everybody that MAVEN Project has an amazing group of dermatologists who volunteer their time to help to support you. And the way that you can access them is by making sure you have an account with MAVEN Project. And if you don't, I'll put my email address in the chat so that you can email me and I can get you set up with that. And then you will have access to our MAVEN Project portal, the community portal. And we have medical experts in 69 specialties. And that includes adult and pediatric dermatology. So this is a list of our 69 specialties. Here's adult dermatology, and here's pediatric dermatology. And you can see our pediatric dermatologist, and here's Dr. Pride right there. And then you can submit your consults all with de-identified patient information, and good photos, making sure that you take a distant photo, seeing the general location of the lesion or rash, and then something that is closer up. And then our docs will get back to you usually within 48 hours and oftentimes less than 24 hours, which is really amazing. So just wanting to let you know that they are here for you and want to help you and support you too. So let me see here. There was a question here. Dr. Bautista, thank you so much. Are there dangerous skin lesions that may mimic these benign ones to be aware of and refer urgently besides the glabellar dermoid?
Yeah, and it's a great question. Um, one of the things I love about pediatric dermatology is the overwhelming majority of the things that I see are really harmless. So I spend a tremendous amount of time reassuring parents that the thing I'm seeing is of absolutely no consequence at all. It's great news. And it makes for a very light, easy day. Of all the things that we talked about, probably the most common significant mimicker is in the pyogenic granuloma class of melanocytic lesions that look like pyogenic granulomas. Now, most of them that mimic a pyogenic granuloma are Spitz nevi. So, as I mentioned, talking about Spitz nevis is a rabbit hole that could take us many hours to get through. But if you were to see a malignant melanoma in a child, it would look like a pyogenic granuloma. It would not look like a angry brown, red, irregular spot the way it would on an adult. So all the ABCDs of asymmetry, border irregularity, color irregularity, bigger than a pencil eraser, you kind of throw them out in pediatrics. So one of the things I absolutely emphasize with our residents, if you take off a pyogenic granuloma, even if you think you're sure that's what it is, it always goes to pathology. The only melanoma that I've truly diagnosed, I've taken care of a few prepubertal melanomas, but the only one that in my career, I've ever diagnosed, I thought clinically looked like a molluscum. So that kind of highlights sort of like that it's not the brown lesion. So that's probably the biggest scary thing. Um, this is in my career. I've had a neuroblastoma and a lymphoma, congenital lymphoma that I've diagnosed. But boy, if that's something I've seen in a 30-year career once, probably not going to be coming across your office all that much. But the pyogenic granuloma thing, I can't emphasize enough. If you're adventurous enough to be taking off pyogenic granulomas, don't throw them in the trash. They always go to pathology.
Great. Thank you so much. And let's see here, another question. If we see a single molluscum alone, it could be a melanoma, did you say?
It's not really the take-home message. uh, it's kind of knowing the numerator and the denominator to this. So yes, the one melanoma that you see in a child, it might look like a molluscum or a pyogenic granuloma or a benign angioma or that sort of thing. But that will be the one on the fraction over the denominator of a million. So you will see infinitely more mollusca than you will melanoma. And remember that the incidence of melanoma in a prepubertal child is 1 in a million. I mean, it literally is. It takes huge cancer registries just to come up with even one case. So, the lesson is, when something's not behaving the way it should, maybe think outside the box. And when you take things off, make sure that you have pathology as kind of like backup on them. But I would not want you thinking mollusca that every single child on the face of the planet gets has a possibility of being a malignant melanoma. That's not the lesson with this.
Great. And she clarifies that she usually sees molluscum as more than one lesion. That's why she asks, since they can be
Yeah.
self-inoculated. Yeah.
Yeah, yeah. I mean, those the multiple ones are what come into the clinic, but I suspect there are a ton of people with just one that never see a doctor for it. It's probably the more normal presentation. They just don't come to the clinic for it.
Mhm. Great. The next question, any systemic workup necessary for urticaria pigmentosa in a newborn? Is there still a concern of malignant transformation of large cogenitalia nevi?
Yeah, I'll answer the last one. Yeah, there is giant congenital nevi, really bathing trunk nevi, particularly if there's multiple satellites around it, have a significant potential to transfer into malignant melanoma. Now, still, most of them don't. This is a number that's gone back and forth like a pendulum through the course of my career, but I think it's probably somewhere in the order of 4 to 6% will turn into malignant melanoma. Now, that means even a giant congenital nevus, about 94%, are not going to turn into melanoma. But just the same, if you were playing the lottery with 5% odds, and that was your child sitting in front of you, that would be a very scary number. So, yeah, giant congenital nevi are of some concern, and they require a lot of close follow-up. The urticaria pigmentosa one, for most children, I don't. If they have systemic symptoms like bad flushing, hypotension, significant belly pain, uh, we'll generally get a workup there. Now, what does that entail? It's relatively aggressive. It's usually a bone marrow aspirate. I mean, at the very least, a CBC and a peripheral smear. You can check histamine levels, not terribly accurate, but for the most part, the run-of-the-mill person with urticaria pigmentosa that maybe has a mild flush here and there, I don't generally feel that they need to be worked up. It's just a general measure of histamine load. A tryptase can be checked. That's a fairly easy test to get. But it doesn't really change my management a great deal over and above what a parent is telling me. So I don't do a lot of testing with urticaria pigmentosa.
Great. Dr. Pride, thank you so much for giving such a great talk today. A huge shout out to Puyallup Tribal Health Authority for requesting this session today, and for all of you who were able to join us. Really appreciate the questions, and also a big thank you to all of the providers that are working in clinics that are caring for underserved patients. We know that you work so hard every day, and we support you, and we hope that you reach out to MAVEN Project for us to help you out when you need it. So I hope everybody has a wonderful rest of their week and a great weekend, and we'll look forward to seeing you at future MAVEN Project educational sessions. Thanks so much.
Hi, everybody.